My today's topic is adrenergic neurotransmitters, which is in unit 2nd in subject medicinal chemistry in B Pharm, and subject code is BP402T. Introduction. The nervous system having various categories, in which central nervous system, peripheral nervous system. In central nervous system we have brain and spinal cord. In peripheral nervous system we have somatic nervous system and autonomic nervous system, and then further classified autonomic nervous system may be classified into two, that is sympathetic nervous system and parasympathetic nervous system. Sympathetic nervous system, that is a preganglionic fiber, originate from thoracic, that is T1 to T2 segment of the cord, lumbar, that is L1 to L3 segments of the cord. Most of the ganglia are located in paravertebral chains that lie on along the spinal cord. Few paravertebral on the anterior aspect of the aorta, that is a preganglionic fibers, are short and the postganglionic fibers are long. As this diagram shows that these are the thoracic, that is T1 and the T2 segments of the cord, and the lumbar, that is L1 to L3 segments of the cord. Neurotransmitter. Our neurotransmitter are basically of three types, that is collectively called as catecholamines, that is noradrenaline, that is represented by Na at the ganglionic sympathetic sites, except sweat glands, hair follicles, and in certain areas of brain. Adrenaline, that is ADR, secreted by adrenal medulla. Dopamine, that is DA, transmitter in basal ganglia, limbic system, that is CTZ, and anterior pituitary. Storage transmitter, stored in synaptic vessels or granules with adrenergic nerves terminal. Vascular membranes actively takes DA from the cytoplasm and synthesize Na, that is non-adrenaline, inside vesicles with help of DA beta hydroxylase. Na stored in complex with ATP, that is 4:1 absorbed on protein chromograin A. In adrenal medulla, Na thus formed diffuses into cytoplasm, where it is methylated to ADR. ADR is also stored in separate granule, that is chromaffin granules. Release transmitters. Depolarization of nerve terminal membrane opens a calcium channel in nerve membrane, and resulting the entry of calcium 2+ promoting fusions and discharging a synaptic vessels. There is a diagram which shows the ATP release, and it converted and formed with post-synaptic neuroreceptors. Regulation of transmitter release. This diagram shows a release of contra-transmitter can be modulated by prejunctional autoreceptors and heteroreceptors. Following their release from sympathetic terminals, all three transmitters are, that is norepinephrine, neuropeptide, that is NYP, and ATP, can feedback the prejunctional receptors to inhibit the release of each other. Enhancement of sympathetic neurotransmitter release can be produced by activation of B2, that is B2 is adrenergic receptors. Uptake of neurotransmitters, that is transport of non-adrenaline, uptake 1, that is non-ephedrine transporter, uptake 2, that is extraneuronal amine transporter, vascular transporter, that is VMAT2. Specificity, Na is greater than Na, Na, A is greater than Na, or Na is equal to A. Location is neuronal membrane, uptake 2 non-neuronal cell membrane, that is smooth muscles and cardiac muscles, or endothelium. Vascular transporter location is synaptic vessels membrane. Other substrates, that is triamine glucuronide, non-adrenaline, histamine, dopamine, 5-HT, inhibitors, cocaine, tricyclic, antidepressants, and desipramine. In uptake 2 steroid hormones and phenoxybenzaimine. and reciprine in vascular transporter. Metabolism of neurotransmitter. Endogenous and exogenous catecholamines are metabolized mainly by two enzymes, that is monoamine oxidase and cathol O methyl transferase. MAO occurs in cell bound to the surface membrane of mitochondria, abundant in non-adrenergic nerve terminals. Comet A, that is catol methyl, a widespread enzyme that occurs in both neuronal and non-neuronal tissues, act as both catecholamines and deaminated products produced by action of MAO. Main final metabolites, that is adrenaline and non-adrenaline, is 3-methoxy-4-hydroxy acid. Receptor regulation. Response mediated by receptors are not constantly same. These processes have considerably clinical significance, that is desensitization, sensitization, up and down regulation, supersensitivity. Drugs that affect adrenergic receptors. Drugs that affect adrenergic neurons are, this diagram shows, adrenergic agonist, that is direct acting drug. Adrenergic agonists are mainly classified into two, that is direct acting, indirect acting, and may be converted into mixed acting. Direct acting is selective, non-selective. Indirect acting is releasing agent, uptake inhibitors, MOA inhibitors, COMET inhibitors. These are the certain examples of selective alpha, affine, codeine, and are different examples of these adrenergic agonists. Therapeutic classification of adrenergic drug. Pressure agent, non-adrenaline, epinephrine, dopamine, phenylephrine, methoxyamine. Cardinal stimulants, that is adrenaline, dobutamine, isopropyline. Bronchodilators, that is isoprenaline, salbutamol, salmeterol, formoterol. Nasal decongestants, that is phenylephrine, oxymetazoline, etc. CNS stimulants, anoretics and uterine relaxant and vasodilators, that is salbutamol, tetrabutylene, ritodine, isopurin. Clinical use of adrenoceptors agonist. Cardiovascular system, that is cardiac arrest, adrenaline, cardiogenic shock, that is dobutamine, that is beta-1 agonist, and heart block, that is beta agonist, that is isopropanolene. Can be temporarily while electric pacing is being arranged. And respiratory system, that is asthma, selective beta-2 receptor agonist, salbutamol, tetrabutylene, salmeterol, formoterol. Nasal decongestants, that is drops containing oxymetazoline and ephedrine for short-term use. Acute hypertensivity. Adrenaline is the first line treatment along with steroids and antihistaminics. Clinical use of adrenoreceptors agonists are as well as same, that is acute hypersensitivity, that is adrenaline in the first line treatment for along with the steroids. Miscellaneous indication, that is adrenaline can be used for prolonged local anesthetic action for miscellaneous indication, that is alpha 2 agonist, that is choline, include hypertension, menopause, flushing, lower intracellular pressure, migraine prophylaxis, obesity, CNS use, that is hyperkinetic children, necrolepsy. Toxicity of adrenergic drug. Restlessness, palpitation, and anxiety, tremor may occur after second injection of ADR. Marked rise in BP leading cerebral hemorrhage. Ventricular tachycardia, fibrillation, angina, myocardial infarction are the hazard of the large dose of ADR. CNS toxicity is rarely observed with the ADR drug. In moderate doses, amphetamines commonly causes restlessness, tremor, insomnia, anxiety. In high dose, a pronopoid state may be induced. Adrenergic antagonist. These drugs which antagonize the receptor action of adrenaline and related drug. They are competitive antagonist at alpha or beta or alpha. They both. Alpha adrenergic blocking drugs and beta adrenergic blocking drugs. Alpha adrenergic blocking drugs have non-equilibrium type, that is beta haloalkyl amines, that is phenoxybenzyamine. In second equilibrium type, that is non-selective. In non-selective we have ergot alkaloid. Ergot has ergotamine and ergotoxin. Second is hydrogenated ergot alkaloid, that is dehydrogenated or hydrotoxin. Imidazolines, that is pentolamine. Miscellaneous is chloropamazine, beta and alpha selective pyrazosone, doxazine and telmisosone. C is, that is alpha 2 selective yomavine. Pharmacological properties: cardiovascular effect, that blockade the alpha receptors, which may induce the vasodilation and thus creates decrease in peripheral vascular resistance, or may fall in BP, that is poses hypotension. Resultant fall in BP, receptor reflex sympathetic discharge since a receptor and blockade. Stimulate beta 1 receptor in heart or tricardia. Alpha receptor blockade absence in the efficiency of peripheral vasoconstriction in erect posture causes peripheral pooling of the blood, which may causes cerebral hypoxia or vertigo with fainting for postural hypotension. Nasal stiffness due to the blockage of alpha receptor in nasal blood vessels. Moises due to the loss of tone and radial moises of iris. Tone of smooth muscles in bladder, trigone, sphincter and prostate is reduced by blockade of alpha receptor. Urine flow in patient with being hypertrophy in prostate, that is BPH, or is improved, that is beginning of hypertrophy prostate. Inhibition of construction of vas defense, that is adjunctive drug of failure ejaculation, that is which causes impotence. Intensity mortality is increased due to the partial inhibition of relaxant sympathetic influence, that is which may some causes diarrhea. Beta adrenergic blocking drugs are non-selective, that is beta 1 and beta 2, without intrinsic sympathetic activity. Propranolol, sotatol, timolol, with intrinsic sympathetic activity, sympathomimetic activities, pinodolol. With additional alpha blocking properties is labetalol and carbidoral. Cardio selective activity, that is B1 is metoprolol, atenolol, acetobutanol, bisoprolol and isomalol are certain examples. Classifying beta blockers into three generations, that is the first generation, which may generally older and non-selective. Our examples are propranolol, timolol, sotalol and pinodol. In second generation we have beta selective agents, that is metoprolol, atenolol, acetobutanol and bisoprolol, isomalol. And third generation we have the drug which is having with addition of alpha blocking and or vasodilator properties, that is labetalol, salpropanol, nebivolol. Pharmacological properties of cardiovascular system: it may decreases the heart rate, it may also decreases the myocardial contractility, conduction, decrease the conduction velocity and the myocardial, decrease the myocardial oxygen demand. Through beta 1 receptor blockade is the main mechanism response for the antihypertensive effect, which may decrease renin release, decrease in central sympathetic outflow, decrease blockade the facility of effect of parasynaptic or B2 receptor on NAE release. Pulmonary system: least effect on bronchial muscles of normal individual. Metabolic effect: inhibits the stress and adrenaline, induce the glycogenesis in type 1 DM, overcome episodes of hypoglycemia, mask the sympathetic manifestation, that is tremor or tachycardia, sweating of hypoglycemia. Adverse effect of lipid profile is decrease HDL, increase LDL and increase triglycerides. CNS effect is decrease in central sympathetic outflow, chronic use lead of sedation, lethargy and disturbance in sleep. Ocular effect: decreases the formation of aqueous humor, decrease intracellular pressure. Therapeutic use is cardiovascular use, that is used in hypertension, congestive heart failure, angina, pectosis, in cardiac arrhythmias, myocardial infarction, that is in decreased incidence, reoccurrence and mortality after long-term use. Non-cardiovascular uses is migraine prophylaxis, anxiety provoking situation, glaucoma, hyperthyroidism, bleeding vesicles associated with portal hypertension. Adverse effect is bronchoconstriction, bicardia, cold extremities, CNS side effect, that is fatigue, sleep disturbance, depression, heart failure, hypoglycemia, adverse sleep, serum lipid profile. Thank you everyone. Here is some views and thoughts on adrenergic receptors. Thank you everyone.